Hello, this is Dr. Oviedo. Today we are going to review the liver pathology of toxins and metabolic disease. This is case 1. At this power, you can see the portal tract right here, and there is a central vein right here. The hepatocytes surrounding the central vein, all in this area here, are necrotic. Let's take a closer look. At this power, you can see the nuclei are degenerating. In addition, the cytoplasm has this dark pink look, and you can't really distinguish the cell borders. These are necrotic hepatocytes. The hepatocytes in this field are still a little bit abnormal, but these are still alive. Going back to this view, you can see the necrotic hepatocytes around the central vein. This, of course, is called perivenular necrosis and is characteristic of acetaminophen toxicity. Let's go on to our next case. Case 2 is alcoholic liver disease with cirrhosis. At this power, you can see this pink material is collagen. When I look a little closer, you can see the collagen is demarcating these nodules of hepatocytes. This is, of course, cirrhosis. Cirrhosis can be the end stage of alcoholic liver disease. In this particular case, this is, of course, cirrhosis. Let's look at the other findings of alcoholic liver disease. At this power, you can see the steatosis. Steatosis means there are fatty droplets inside the hepatocytes. This is abnormal, and these, of course, are the fatty droplets. Here's one here, here's one here, here's one here. There are, of course, quite a few. In this view, you can see these dark pink collections within the hepatocytes. There's one right here, one right here, and one right here. These are Mallory-Denk bodies. Mallory-Denk bodies are abnormal accumulations of intermediate filaments in the hepatocyte cytoplasm. They are commonly seen in alcoholic liver disease. In this view, you can see a small cluster right here of cells that appear to be neutrophils. They appear to be attacking a hepatocyte. This particular finding is called alcoholic hepatitis and is, of course, seen in alcoholic liver disease. This case showed steatosis, alcoholic hepatitis, and Mallory-Denk bodies, which are very characteristic of alcoholic liver disease. In addition, this liver is, of course, cirrhotic. Let's go on to our next case. Case 3 is non-alcoholic fatty liver disease, which is associated with metabolic syndrome. This particular entity is also called NASH, which stands for non-alcoholic steatohepatitis. In this view, you again have these white circles which represent the steatosis. Here's a fatty droplet, here's a fatty droplet, here's a fatty droplet. This is steatosis. In this field, I've shown you a central vein right here. This central vein has collagenous fibrils extending from it here, here, and here. These collagenous fibers are, of course, abnormal. Sometimes they are referred to as chicken wire fibrosis because if you look carefully, they sometimes do have kind of a chicken wire appearance that kind of wraps around hepatocytes. You can kind of see it in this area right here. If this chicken wire fibrosis progresses, you will get bridging fibrosis. Let's see if we can find some bridging fibrosis in this case. This particular view demonstrates a much thicker band of fibrosis, which is known as bridging fibrosis. It is a more severe form of fibrosis and represents more advanced disease. This case demonstrates steatosis, chicken wire fibrosis, and bridging fibrosis. This is non-alcoholic fatty liver disease. Please note that non-alcoholic fatty liver disease and alcoholic fatty liver disease have similar pathology. They both also have a spectrum of disease depending on the clinical course of the disease. Let's go on to our next case. Case 4 is hemochromatosis secondary to transfusions for beta thalassemia major. Let's take a closer look. Here on the left, you can see a portal tract. I'm going to take a closer look at the hepatocytes here on the right. At this power, you can see the hepatocytes have an abnormal brown pigment, which represents the abnormal deposition of iron. In order to confirm that this is iron, we generally do a Prussian blue stain, which will confirm this brown material is iron. Let's go on to look at our Prussian blue. This is the Prussian blue on the same liver biopsy. At this power, you can see that the granules in the hepatocytes are blue, which confirms that they are iron. This, of course, is hemochromatosis secondary to transfusions for beta thalassemia major. Excess iron deposition from genetic hemochromatosis will have a similar pathology to this particular case, which was due to excess transfusions. Let's go on to our next case. Case 5 is Wilson's disease with cirrhosis. This is the MRI from the patient. This is an axial flare image which demonstrates abnormal signal in the caudate right here and the putamen right here. This abnormal signal is due to damage from excess copper deposition. Let's go on to the next image. This is a close-up of the eye. You can see the Kaiser-Fleischer ring is represented by this brown material at the edge of the cornea right here. Kaiser-Fleischer rings are very characteristic of Wilson's disease. Let's go on to the liver. At this power, you can see that this liver has cirrhosis. These dark pink bands forming small nodules of hepatocytes is, of course, cirrhosis. Let's take a closer look. At this power, you simply get a closer view of the bands of fibrosis forming nodules, which is, of course, cirrhosis. This is the end stage of untreated Wilson's disease. Let's go on to the next case. Case 6 is alpha-1 antitrypsin deficiency. This is a PAS stain. Here you can see a portal tract. The hepatocytes are stained fairly dark with the PAS due to their glycogen content. The PAS doesn't demonstrate any significant abnormalities. Let's go on to the PASD. PASD stands for PAS diastase, in which diastase has digested away the glycogen. After diastase digestion, you should only be able to see abnormal structures. Let's take a closer look. This is a portal tract right here. These pink globules, which are small here and larger here, these represent abnormally folded alpha-1 antitrypsin. This abnormally folded alpha-1 antitrypsin will trigger the unfolded protein response and may lead to apoptosis of the hepatocytes. That is the basis for liver disease and alpha-1 antitrypsin deficiency. Let's go on to our summary slides. Case 1 is acetaminophen toxicity with perivenular necrosis. Here is our slide. At higher power, you can see the perivenular necrosis. Here is our portal tract. Here is our central vein. And this gray color represents the necrotic hepatocytes. This is the higher power of the necrotic hepatocytes. And down here, I've put normal hepatocytes for comparison. Case 2 is alcoholic liver disease with cirrhosis. Here is the liver with cirrhosis. Here is the steatosis, which is the white circles which represent fatty droplets in the hepatocyte cytoplasm. Here I have neutrophils reacting towards a degenerating hepatocyte, which is known as alcoholic hepatitis. Here I have numerous Mallory-Denk bodies, which are abnormal accumulations of intermediate filaments in the hepatocyte cytoplasm. Here's one, here's one, here's one, and here's one. And finally, I've shown the cirrhosis, which can be the end stage of alcoholic liver disease. The bands of fibrosis form around nodules of hepatocytes, which is, of course, the appearance of cirrhosis. Case 3 is non-alcoholic fatty liver disease, which is associated with metabolic syndrome. This is also called NASH, which stands for non-alcoholic steatohepatitis. Here is our slide. Here is the higher power demonstrating the steatosis, which are the white circles inside the hepatocytes. This fat will be positive with oil red O stain, which I have not shown here. Here is a fatty droplet, here is a fatty droplet, and here is a fatty droplet. There are quite a few. Down here I've shown fibrosis around a central vein. The pink fibrils are collagen. You can see they have kind of a chicken wire appearance. Here is the central vein, and here is the fibrosis. Here, here, and here. If the chicken wire fibrosis progresses, you can then have bridging fibrosis, which is shown there on the right. The bridging fibrosis is present here and here. Non-alcoholic fatty liver disease and alcoholic fatty liver disease have similar pathology. Both also have a spectrum of disease depending on the clinical course. Case 4 is hemochromatosis secondary to transfusions for beta thalassemia major. Here is our biopsy demonstrating brown pigment in the hepatocytes. Prussian blue stain confirms that the pigment is iron. Hemochromatosis also has a genetic form. The most common genetic form is HFE loss of function mutation. Other organs affected in iron overload include pancreas, myocardium, endocrine glands, joints, and skin. Case 5 is Wilson's disease with cirrhosis. Here is our axial flare MRI, which shows abnormal signal in the caudate and putamen due to damage from the excess copper. Here is the Kaiser-Fleischer ring, which is this brown ring along the edge of the cornea. Here is cirrhosis because this was a case of end-stage Wilson's disease. Wilson's disease is autosomal recessive and due to ATP7B mutation, which causes impaired copper excretion into bile. Ceruloplasmin levels will be decreased. The definitive diagnosis is generally made with the copper content in liver tissue. Case 6 is alpha-1 antitrypsin deficiency. This is the PAS diastase, which shows the abnormal cytoplasmic granules in the hepatocytes, which represent abnormally folded alpha-1 antitrypsin. These will trigger the unfolded protein response, which may lead to apoptosis. Alpha-1 antitrypsin deficiency is autosomal recessive. There are many different mutations. In the lung, you can get emphysema when the proteases are not inhibited. Okay, that's it.